The later diagnosis is made for oral cancer, the worse the prognosis is, the more likely the surgical procedure performed will be more radical, disfiguring surgical procedures, probably loss of function, that means difficulty eating, difficulty speaking. They have to be concerned, of course, about the prognosis, the long-term prognosis, which could be death. They also have to look forward to the possibility of radiotherapy and chemotherapy with the side effects that bears with it.
I can't eat anything, not even soup. I can't drink anything, not even water. Everything comes to a tube, it opens in here and goes into my stomach. So everything is like my nutrients out of a box. So it's horrible.
The lining of your mouth should be pink. If there's a white patch that's there, it needs to be investigated. And the only way to determine the diagnosis is to biopsy these lesions.
Oral cancer is best screened in the clinician's office, and the best tool they have is their eyes and their fingers. That is a good clinical examination. There are some tools available on the market, but their efficacy is questionable. The pathologist looks at the tissue and decides whether there is or is not cancer there, or at times a more difficult situation is when there is the potential for a cancer to develop. In other words, the pathologist sees what was called this dysplasia in the biopsy, which suggests that there may be a possibility of cancer developing. There are certainly challenges for the pathologist in making the diagnosis, not so much for the diagnosis of cancer, because that's usually pretty straightforward. More often, the difficulty is the diagnosis of the premalignant or possibly premalignant lesions, because that's very subjective, and there's a variation between pathologists on what criteria they think is more or less important. And then even within a single pathologist, from day to day, their criteria or their standards may change very slightly. Straticyte is an assessment tool applied in the laboratory by the pathologist to this material that he or she is examining. The Straticyte allows you to not only say there is or is not dysplasia, or how severe it is, but to give an assessment of the likelihood that that lesion will go on to become cancer.
I've not had really anything objective to use to provide them some reassurance, to have some predictive value other than my assessment of the patient. Are they heavy smokers? Are they heavy drinkers? We know that those risk factors are changing a little bit. If I had a test that could provide me with some predictive value as to whether this patient was going to go on to develop cancer in the next 5 years, then it would be extremely useful for me. It would be extremely useful for them. Patients that have had a mild dysplasia diagnosis that in the past I would not have been concerned about, but having gone through Straticyte assessment, we found that in fact their risk is far higher than I may have appreciated. And at the same time, I've had patients who have had a diagnosis of serious dysplasia that have had Straticyte assessment done, and their risk has been found to be low. And so the management of my patients has changed completely. Now Straticyte becomes the assessment that I use to determine how closely these patients are going to be followed. We finally have a way of objectively assessing these patients and predicting their future potential for developing oral cancer. We have an assessment which will guide my follow-up.
Straticyte gives the healthcare professional an additional tool to help him or her take care of their patient. They can decide whether to treat a lesion earlier or later, or not treat at all, whether they need to only observe or actually go in and do something surgical further. More important at times is to allay anxiety for a patient. The patients are always nervous. They've had a biopsy. That means often to a patient cancer. To be able to say to the patient, this is likely to go on and therefore we're going to do something, or this is highly unlikely to go on and we will still keep an eye on it, but you don't have to worry.
I broke out in a spot on my tongue, and I looked at it and it looked like a canker. Within 5 days I was in here and had it removed, and 7 stitches in my tongue and the whole bit, and I healed nicely. And then Dr. Rennick was telling me that I was the second person if I wanted to be enrolled into this study, and that he would have a good idea then when it came back, the reoccurrence or the percentage of what it might turn into cancer. So I said, oh, definitely, let's go for it, just for peace of mind alone. Once I got the Straticyte results back, it was a big relief. So if a family member or a friend came to me and told me that they had had a sore in their mouth, whether it's in their gums, their tongue, or the side of the mouth, and it had been there for a while, I would definitely tell them to get in and seek medical attention right away.
And my odds of survival at that time to a was considered to be about 1 in 5. Now I was fortunate, and I say that only because if you want to live your life like this, it's nuts.